I must thank the organizers, not only for the wonderful hospitality, but the superb organization that has been very evident during this conference. There has been considerable interest in the UEMS EBS General Surgery exam, and this is the reason why I'm talking about it, especially to stress the extra-European outreach, whether this is just utopic or reality. Some questions come naturally. Where is a European specialty exam applicable? Is it applicable to small states like Luxembourg, Cyprus, Malta, or even Belgium, or to larger states? Why an extra-European outreach in this context? If we look at the world map, then you will immediately notice that the so-called big states are not so relatively big after all. Even Europe as a whole, compared with Asia, looks tiny. Also, if we define a continent as a land mass, which is separated from other land masses by an ocean mass, then it is a bit debatable whether we can call Europe as a continent at all. Is there a need for a European exit exam? I think big states need it because of the directive on professional mobility by the EU, problems could arise. And one needs assurance of standards for the sake of patient safety. The small states need it to have a critical mass, to have quality assurance, and to assure equity. And we are not here talking about a particular specialty, we are talking about all specialties. Now, if this is applicable to all states and all specialties, then we shall really have an extended harmonized area for postgraduate medical specialist training. And this would be in the interest of harmonization, quality assurance and improvement, maintenance of standards, equity, professional mobility with safeguards, and patient safety. Some statistics. 15% of European specialists come from outside the EU. The cost of training a general surgeon is about $250,000. But if one calculates what is spent from kindergarten onwards, more globally, it is much more. There is a rising median age of general surgery surgeons in Europe and in the US. At the moment, it's in the urban areas, it's 48 years, and in the rural areas, the mean is 53 years. That is worrying. The growth in number of specialists in general surgery is much less than the population growth. What are the effects of these? If we look at the workforce trends that we have been describing and the rising demands despite decreasing trauma in Europe, it's pointing clearly to a crisis. So, what is an exit exam in general? And what is our exit exam? It leads to eligibility for CCST, but not an automatic conferment, having completed the training program and satisfied all the requirements of the relevant curriculum. It provides supporting evidence for specialist registration. It leads to eligibility for independent practice subject to authorization by relevant bodies. The UEMS EBS General Surgery leading to FEBS is a quality mark for training in general surgery. Passing this exam does not give the right to practice in any UEMS member country. This is clearly written in the Glasgow Declaration, Appendix 1.3. Such a right is only granted by the relevant national authority. And the Glasgow Declaration was put forward by CHESMA in 2007, so it's been there for quite a few years. Why general surgery at all? It is necessary for pigeonholing, more comprehensive treatment and continuity, staffing of district general hospitals, hospitals in small island states and small islands off the coast of larger states, training surgeons for service in third world countries, dealing with emergency surgery, and training emergency surgeons where this specialty has taken root. So general surgery is not dead. Speaking about the UMS, EBS.2 General Surgery exam, the fellow of the European Board of Surgery should be considered on par with the UK Intercollegiate, FRCS, FACS, etc. The role of the UMS, EBS.2 General Surgery examination is to be considered as complementary to the national examinations where these exist. Countries which do not have their own national examination are encouraged to adopt this exam as their exit exam for specialist registration in general surgery. Candidates who pass this exam are awarded the title of Fellow of the European Board of Surgery, FEBS, and receive the corresponding certificate. Candidates must be medical graduates who are either certified specialties or in their final year of specialist training in a UMS recognized specialist training center. Candidates of any nationality are eligible. The published curriculum and eligibility criteria are obtainable from the UMS section and board website. One needs to make some clarifications because this is where the queries come about. Certification of completion of training, CCT or CCST, is not awarded to trainees homogeneously in all EU states or in all countries. Some countries require that the candidate passes an exit exam before even applying for a CCT. Others confer it to those who pass a national exam. Others still to those who pass a local exam. And there are still many countries who confer CCT or equivalent without any exam whatsoever. So there is no homogeneous way of conferring this. It is necessary to have a competent authority which confers CCT. For example, the Specialist Accreditation Committee in some countries, the General Medical Council in UK. The other query that often comes up is the one of recognition. This is actually a very relative term. Though the EU directive on free movement of professionals is in place, it is the national competent authorities which decide. Competent authorities such as GMC, SAC, ECFMG, etc. National legislation for automatic recognition is required. And this can be done either through unilateral or bilateral agreements. A national framework for qualifications and levels is necessary. Comparability statements for qualifications, for example, a directory for equivalence, is also necessary. This has to be developed. Occasionally, one has to resort to precedents, legal precedents. Just as an example, there was a vascular surgeon coming from the continent, working in UK, whose qualification, UMS qualification, was challenged. The case went to court, and the court decided that there was complete equivalence between the FRCS and the UMS EBS.2 qualification that he had. In my opinion, the best option for the EU to clear all these problems is to merge the postgraduate medical training with the modified Bologna process. But this is unlikely to happen because the third cycle of the Bologna process is having a lot of birth pains. What is the content of the exam? As usual, knowledge, skills, and attitudes, professionalism, that is. In the evaluation, one tries to be as objective as possible. One has MCQs, OSCEs. One could also have objective structured assessment of technical skills or global operative assessment of laparoscopic skills. But at some point, there will be a subjective element. Even numbers on a Likert scale at the end of a rotation, despite their being numerical, are actually subjective. Narratives are obviously subjective. However, there's need for evaluation. First of all, to remedy deficiencies, but also because of the impact it has on patient safety. What assessment prerequisites are necessary? Appropriateness and relevance, standardization, validity, reliability, objectivity, transparency, and equity. One cannot take one aspect of this in isolation. One has to take them globally, as this cartoon tries to portray. What we strive to achieve are clear exam regulations, sufficient resources to support assessments, compliance with legislation, data protection, and equal opportunities, quality assurance, potential for quality improvement, consistency of approach across and within various specialties, and review and appeals procedures. What is important that the eligibility criteria are clear and unequivocal, that the curriculum is competence-based rather than number-based, and that the syllabus has flexibility, and the reasons are that there are diverse emphasis in the various syllabi that are produced from the different states. And when you try to get these together for a European syllabus, one encompasses everything, but one cannot expect each candidate to be highly proficient to that extent in all these various points of emphasis. Quality assurance. This must be both internal and external. There is a body, CHESMA, where they are extremely competent in doing this external assessment. Visitation and certification of training centers is also necessary because it's not logical to assess the product and not the machinery that produces it. There is a body called NASCE that is really concerned with skill centers, but in my opinion should widen their scope to the whole spectrum of postgraduate medical training. A competence assessment form which is widely used and is accepted by all would be a great help. It is usually in 4 sections, each of which involves several elements, such as overall professional capability and patient care, knowledge and judgment, quality of response, bedside manners, and related aspects. The assessment pathway is cyclical. So you plan the assessment, you do it, you judge the evidence, you review the progress, and then from what you learn from this review, you plan the next assessment. There are problems, of course. There are technical problems such as language, diverse emphasis and attitudes that we have spoken about. There are political problems such as Euroscepticism, neo-nationalism, defeatist attitudes, and the determination of local authorities to retain total control of career structures, advancement, and allocation of posts. This is a real problem. There are also solutions. Language problem, well, I think the clearest way of doing it is to have a lingua franca. At the moment, the best candidate for a lingua franca is English, but it's not said it will be always so. It could be Chinese in decades to come. You can have a lingua franca with an escape clause that is mainly English, but with the possibility to use another language providing translators for the benefit of examiners and quality controllers. I must say I have a few misgivings about this, not because it doesn't work, but one cannot really be completely 100% sure that a translator who must be technical to translate technical language and mostly is local wouldn't be answering himself. In other words, whether the answer would be coming from the candidate or from the translator, and that is a worry. However, I must say that the other alternative, any language with translators, has been adopted by the section of anesthesiology, and they're extremely happy with it and doing very well. One could leave it to the sections to decide, which is one way of passing the buck. Diverse emphasis and attitudes could be countered, as we have already said, by the correct degree of flexibility in competence-based assessments. There are proposed developments, such as a European-based validated e-learning and e-assessment program, a central electronic collection and evaluation of continuous assessment results with feedback, an e-portfolio that is, which is going to be put in place soon, I hope. The thorny question of revalidation and adequate and transparent funding. Pan-European professional improvement depends on innovation, but also on participation of member states. That is, there must be the political will to do this. There are future stages that one can think about, and if one has vision, must dream in this way. The first stage is establishing and consolidating exit exams in all specialties. This has been done. Second step, all national authorities to recognize the European postgraduate qualification. This has been done, but only in part. All national authorities to abandon their national exit exam in favor of a European one. This has been done only by a handful of states. And fourth is convergence with the Bologna process, 3 cycles, with the development of a separate rail in the 3rd cycle, that is the one leading to a doctorate, adopted for the longer period of postgraduate medical training. Now, when we say this, one must specify. The first cycle is 3 years leading to a bachelor's degree in medical sciences, and it's undergraduate. Second cycle, 2 to 3 years leading to a master's degree graduation as a doctor. The third cycle is 3 years leading to a doctorate, postgraduate, a PhD. But here, we would like to graft the European postgraduate medical training program, which would be a much longer process, and this would lead to a European Specialty Board qualification. If we do this, it would lead to a real extra-European higher education area, which it would be most commendable. Can we do this? I think we can. With vision, goodwill, and expertise, DUMS and DSS have got the resources to put this in practice.
Mark of a good surgeon is when he can finish the operation in time. Very good.
No, it is a global thing. All nationalities can apply, and it has always been like that. I mean, the UMS and the ESS have always opened up to countries which were not EU states. But now we're going even further, as you heard from Professor Terzi. Our next Congress will be in China and Beijing, and hopefully there'll be an exam there. So there you are. Thank you.
Thank you, Dr. Arthur. Our next eminent speaker is Professor Field. He is the president of European Board of Surgery. He is a professor of surgery, medical director and department general surgery, visceral surgery, EKWH Wien. And he is also the founder and honorary president of UEMS. Division of General Surgery. He will be discussing about metabolic and bariatric surgery, a European Board Fellowship. Professor Field.
Thank you very much for the kind introduction, Mr. President, the Chairman, esteemed audience. At first, thank you very much for the invitation to come here to this marvelous place and to this exciting community. And let me express my deep gratitude and appreciation, especially to Vinod for his perfect organization. It was a tremendous work. Congratulations. Thank you very much, Vinod. So, on behalf of the European Board of Surgery, best greetings to the esteemed audience, and I would like to introduce the upcoming project of a fellowship program for metabolic and bariatric surgery. But at first, when we talk about a European Board Fellowship, we have to define what is Europe. We already heard from Arthur that, well, we know Europe is not a clearly defined continent. It's not defined by geography. It's not defined by countries. It's somewhat defined by culture and history. But we find a huge and vast diversification in ethnics and in religion and in language and also in economics and politics. Well, overall, it's a place where people live and work, and there's, you know it from the media, a very significant migration process into Europe coming from the North African countries and also from the Mediterranean, and we have to take care for this. The European community and the European Union started in 1957 with 6 countries. And what you see here in North Africa as a blue dot, this is Algeria. At that time, Algeria was part of France. And so at that time, an African country was already part in the European community. Meanwhile, the European community has 28 countries and more than 500 million inhabitants. And we can say proudly that it's the largest peacekeeping project in Europe ever. And meanwhile, we have also more candidates for EU membership. The main principles in the EU are the freedom of movement, the freedom of services, and the freedom of labor. And what we share in our legal system is the principle of subsidiarity. And we are regulated by laws and directives, but there's also quite much place for federalism, unfortunately also nationalism, but mainly for particular interests in the member states. Big issue is the situation that we have 25 languages. This is a situation what other communities like the US do not have. We have in all countries in this federalistic system quite a number of national and regional regulations in medicine, because we talk about the medical education. We have, due to the fact that we have this principle of subsidiarity, a process with automatic recognition of diploma, which means, let's say, a general surgeon who has a CCSD for general surgery in Spain may move to Poland and work there as a surgeon. So there were quite a number of complications coming up with the extension and the new countries in the EU, which made it necessary to bring some control into these structures. And the UEMS, the Union of European Medical Specialists, is now an official advisory body for the EU. It's an NGO, a non-governmental organization. It's an NPO, it's a non-profit organization. And we have the mandate by the European Commission to work as an advisory board. So there's quite a number of tasks for the UMS. It's promote the free movement, but it's also harmonization and standardization at the highest level of specialist training, and it's also to take care for the EBS-Q process, which is the European Board of Surgery qualification process, by facilitating the board examinations and to cooperate with the scientific societies. So two keywords for the processes in the UEMS are harmonization and standardization. Harmonization usually meant that we should, it was our task, that we should harmonize the denominations of medical specializations, not based primarily on educational contents, but on the denominations. And this turned out to be, well, it turned out to a non-working process. It's better now what we do, that we switch to standardization, that we pay respect to the fact that we should have good standards, not based exactly on denominations, but more on contents and on training. So the white book for this established process training requirements is the book General Surgery, where we put together our training requirements and where we found the structures for the qualification process leading to the title Fellow of the European Board of Surgery. The qualification process is a two-step process consisting of eligibility and examination. There are clear-cut, precise, and crystal clear structures for this. We have an eligibility committee giving clear rules who is eligible for the application and for the examination process. We have an examination committee taking care for the composition and for the quality of the questions. We have a credential committees if there are problems after the examination. We have also preparatory courses and other quality structures. The concept now is to bring a system with fellowships for transferable competencies. We drew back from the denominations like surgery or these things. We drew back from it because there was a jungle of different names meaning the same, GI and visceral and all these things. And we switched to more honest and clear-cut logbooks, enhancing rotations, but considering all the national peculiarities of the contents. Well, let's say in general surgery, if you do harmonization alone in general surgery, this could mean that you leave quite significant content. In some countries, thyroid surgery is not part of general surgery. So if you do harmonization alone, you will have to omit it. It's the same issue with breast surgery, flexible endoscopy. This is why it is better to switch more to a competence-based concept. Contents, competencies, and qualification. These are the keywords for our modular concept in providing surgical qualifications. On the left side, you see the already established qualifications, and on the other side, the project, the running project. This year, we introduce esophagus, cardia, and stomach surgery, and there are also some other projects like emergency, metabolic, minimal invasive, and others. And what we are talking about now is the ongoing project to introduce the qualification for a European Board Fellowship in metabolic and bariatric surgery. By the end of March, we have our meeting in Berlin, and this will be the time to introduce at first the working group and later the division and the board of metabolic and bariatric surgery within the UEMS section of surgery. Most of the basic things are already done, like the formal things, putting up the statutes and all these things. What we need now is to fill this framework of structures with the foundation committee to define what should be in these transferable competencies. This will include to produce a syllabus, also to produce a catalog with knowledges and skills, and in the next step, when this is done, to clearly define the eligibility criteria for the examination and to conduct the examination itself. So the first step is the definition of what should be in this subspecialization, as it has been called. We call it now transferable competence. It is the content of training, it's the learning outcome, it's the recognition also of training institutions, and it's the list of requirements, which includes the theoretical knowledge, it also includes the practical and clinical skills, it also includes the logbook with numbers in certain categories, also providing provisional rules for compensations if, let's say, one center has more, let's say, gastric bypasses and the others has more sleeves, and then to produce the eligibility criteria following the basic EBS, European Board of Surgery, regulations. This means also that we can include in the logbook credit points for publications, for congresses, for courses, and also have the possibility to create honorary diploma for specialists in the field of metabolic and bariatric surgery who will not go through the whole examination process because they are renowned experts and have the possibility to receive the honorary fellowship. The examination will follow the basic structures of the European Board of Surgery, which is a combination of a multiple choice test with 100 to 150 multiple choice tests and an osteocircuit with 6 stations. We have to put together the people for the examination committee, and this committee will have full support within the European Board of Surgical Qualifications. So what we can do now in the moment, and what I will cordially bring is an invitation to you all who is interested, and in the coffee break I also found the first esteemed colleagues who are willing to cooperate in this process. Lucky day. So is to find the foundation committee and then immediately start with the definition and the syllabus and with the knowledges and skills, and we have when we can make it to have a basic framework of this by the end of March, we can go through the legal processes within the UEMS and could have an examination by 1 year. So cordial invitation to you all. Thank you very much for your interest.
Interesting and a very great approach, because one of the difficulties is having a good standardized definitions and exams, especially for bariatric surgery where there's a high problem of complications. I think having a standard will help. And that's what in America also we are toying, and I was discussing in break with you. And one of the difficulties we have is the volume of cases, because there's a strong push to have at least 50 bariatric gastric bypasses before the certificate is awarded. So are you also struggling with something like that, that there should be a certain minimum number of advanced bypass cases?
Well, our rules in general surgery provide also compensations, meaning there is a number of operations you have to perform, a total number. And let's say if you in general surgery are a little bit more specialized in one region, you may compensate to the full number of operation in another field. So let's say maybe it could be an idea for bariatric to say, okay, a minimal number of gastric bypasses. If you have more, you may take compensation from another field of bariatric surgery.
That's a great idea.
But these basic structures and regulations are already put down in the training requirements for general surgery. So the only thing, it's not necessary to invent the wheel by new. We can take all these rules and adapt it to our purposes we need for metabolic and bariatric.
I think Dr. Fried has a question.
Yeah. Good evening. I'm looking forward to have an informal talk with you tomorrow, let's say. I would like just to answer your question. There is also European chapter of the International Federation for Bariatric Surgery, which is very active in Europe. It issued its guidelines for bariatric and metabolic surgery, which has been published, the second edition last year. And also there is a well-defined structure for being recognized as a center of excellence in bariatric surgery. And there is a definition of number of bariatric procedures, of number of surgeons who should be in a center, who should serve, and also there is firm requirements for qualification of bariatric and metabolic surgeon. So this is already done and established and was published, so I'm looking forward to talk to you and try to find out a solution
Thank you very much.
the European Surgical Society will just can take and copy-paste the whole thing hopefully in cooperation with this already existing body, which exists since 1996.
Yeah, perfect. Thank you very much. So that's also a reason why we are here, to meet and to talk. So we appreciate this very much, and we can implement these things very easily in our common concept. Thank you.
Since we are finished with UEMS and we have those certificates, now we will go inside the OT. I'll invite Professor Luke, the senior most young surgeon with us. He is the Chief of Surgical Services in Belgium, Academic Hospital of Montgomery. He is a full professor of surgery at University of Leuven Medical School. He is the Director of Complete Residency Program in Surgery, Montgomery University Hospital, and he is the President of Medical Council of Montgomery University Hospital. He will be presenting on surgical checklist in the operation theater. So we move on into the operation theater, a most vital area, which is usually not covered every time.
For your invitation, Mr. Chairman and dear colleague. I have the chance to share with you some of my experience with a very old problem. This is a first statement that is quite optimistic. Medical errors are largely a problem of the system and the atmosphere surrounding healthcare, and not an allocation of blame to individual physician. Well, when we have to speak about this topic, we have a problem of semantics. And the first problem is the difference between a risk and a danger. The difference is very subtle. The risk is when you purposely do something that will put you in danger but could produce a greater outcome, sometimes positive. Danger is a situation in which there could be a risk that you don't want to take. In other words, life and surgery are risky. The patient and his surgeon or her surgeon are in danger. But let's put some figure on the risk for surgeon. Here the figures are less optimistic. Recent paper in the New England Journal of Medicine 2000